Welcome back to the 365 Days of Medical Knowledge series. Today on day 35, we are looking at antiplatelets in primary care. Our guiding principle is simple: right patient, right drug, and right duration platelet activation. And aggregation play a key role in arterial thrombosis. By reducing this activation, antiplatelets lower the risk of myocardial infarction, stroke, and vascular death in high-risk patients. However, keep in mind, antiplatelets are recommended for secondary prevention, not for primary prevention in low-risk individuals. Key indications include a history of MI ischemic stroke, or TIA, post-PCI or coronary stents, peripheral arterial disease, established CAD, post-CAPG, post-vascular surgery, and chronic kidney disease with high cardiovascular risk. When choosing an agent, always prefer the lowest effective dose. Your standard options include aspirin dosed at 75 to 150 milligrams once daily. It's inexpensive and effective, though it carries a risk of GI irritation and bleeding. Clopidogrel at 75 milligrams once daily, which serves as an excellent alternative to aspirin with less GI irritation. Ticagrelor at 90 milligrams twice daily is a more potent option preferred for ACS and post-PCI. Prasugrel at 10 milligrams once daily is also used for ACS and post-PCI, but it must be avoided in patients with a prior stroke or TIA. When combining aspirin with a P2Y12 inhibitor for dual antiplatelet therapy, duration matters. For ACS managed medically, or ACS with a drug, eluting stent PCI, the typical duration is 12 months. For stable CAD with a drug, eluting stent PCI, it drops to 6 months. For high bleeding risk patients, consider a shorter duration of 1 to 3 months. After DAPT, remember to continue single antiplatelet therapy, usually aspirin, and adjust based on the patient's bleeding and thrombotic risk. Before prescribing, always assess bleeding risk using an adapted HAS bled score. Evaluate factors like hypertension, abnormal renal or liver function, stroke history, bleeding history, labile inars, age over 65, and drug or alcohol use. A score of 3 or higher indicates a high bleeding risk, requiring a review of the need, dose, and duration. Watch out for absolute contraindications, active major bleeding, a history of hemorrhagic stroke, severe bleeding diathesis, aspirin hypersensitivity like asthma or urticaria, and severe thrombocytopenia. Use antiplatelets with caution in patients with peptic ulcer disease, the elderly over 75, those with CKD, or anyone taking concomitant NSAIDs, steroids, or anticoagulants. Consider gastroprotection with a PPI in high GI risk patients. Interactions and patient counseling. Be aware of key drug interactions. Concomitant use of NSAIDs or steroids increases the risk of GI bleeding. SSRIs and other antiplatelets increase general bleeding risks, while anticoagulants like warfarin, DOAX, or heparin significantly elevate the risk of major bleeding. When counseling patients, advise them to take their medication regularly as prescribed and never stop on their own. They must report unusual bleeding immediately, such as nosebleeds, bleeding gums, or black stools. Aspirin should be taken after food to reduce stomach irritation. Remind them not to miss doses, especially after a stent, and to always inform any doctor or dentist before undergoing procedures. In special situations, decisions must be individualized by balancing ischemic benefit against bleeding risk. Before surgery, continue aspirin in most minor procedures, but stop clopidogrel 5 days before elective surgery if the risk is low. During pregnancy, avoid antiplatelets unless essential. For elderly patients, use the lowest effective dose and monitor closely for bleeding. For CKD, no dose adjustment is required for most agents, but close monitoring for bleeding is essential. Finally, proper documentation and follow-up are critical. Clearly document the indication, choice of agent, dose, duration, and review plan. Continually review for side effects and adherence, and reassess periodically to de-escalate therapy when appropriate. Regular review means safer therapy. To wrap up, let's review the key takeaways. Antiplatelets are for secondary prevention. Aspirin is your first-line agent, with clopidogrel if it's not tolerated. Use DAPT for the appropriate duration only. Always assess bleeding risk and drug interactions. Use the lowest effective dose, educate patients and ensure strict adherence. Right? Antiplatelet, right duration. Better outcomes? Follow us on Instagram, Facebook and YouTube for more daily medical insights. Thank you.